Okay. Again, good morning, everyone. I'm Ben Morey with Milliman, and we've been engaged by MedQuest to do the ABA rate study. Thank you for getting back together again. This is our second stakeholder meeting. And so before we get started with the presentation, we'll just do some quick introductions. Again, Ben Morey with Milliman. I'm also joined by my colleagues, Dennis Finnegan and Dalal Al-Batati. We also have the State of Hawaii MedQuest division on the line today. And so I'll let John introduce himself and the team.
Good morning, John Fuji. I work with the Healthcare Services branch with the MedQuest division. And like Ben said, we, as a state Medicaid agency, contracted with Milliman to conduct a rate study for our ABA services. And again, really thankful and happy that folks are on this call, wanting to get into a little bit more detail around some of the components of the rate study. I believe Sharon Thomas is on the call as well. I can't see her here, but I know she was on. I think she's dropped off accidentally.
Oh, I made it back on, John. Thanks. So my name's Sharon Thomas. I'm a nurse within MedQuest Healthcare Services branch and helping to guide along this rate study. And, you know, to not take up much more of your time, but also to move forward, we would like to record this session and would like to go ahead and start recording that now. If for any reason folks are not comfortable with us, what we have been doing is we've been recording and then sharing that out on our webpage. If anyone has any hesitation or does not want us to do that, please let us know, but we're going to go ahead and start recording now. And then I'll pass it over to you, Ben and Dalal.
Okay. Thank you, Sharon. Okay, so what we'd like to do today, we've had the kickoff meeting here earlier in the fall. We had a discussion related to the provider survey. So we wanted to follow up and have a discussion. And most of this is going to be where we would like to get your feedback, your input on a discussion related to your staffing approach, challenges that you have in terms of staff retention, recruiting, training, et cetera. And then also a discussion on your service delivery model. And all of this is to help us better understand your service delivery system to make sure that we have the best possible context for when we develop the assumptions that go into the rate calculation. So if you've seen the presentation, and this was sent out before the meeting, but if you've seen it, we have scheduled a follow-up meeting, a meeting after this, where we will be sharing draft rate calculations. So the draft rates are to follow this. This is something that we will be following up with the group on. But before we got too far ahead of ourselves in terms of the rate calculations, we wanted to make sure we had a strong understanding of your service delivery system. And so it is just really helpful to have your feedback and your comments on the call today. So we'll stop at several points and open it up in terms of you be able to contribute and provide feedback. If you want to enter anything into the chat, you can do so. Obviously, we can go off mute, and you're welcome to speak on the call here. But are really looking forward to your participation. And it's helpful context, and it helps to add more to the survey information that we've received. And thank you for those of you who responded to the survey. Appreciate your participation in that, and that's very helpful. But having this discussion to supplement that is also very helpful. So thank you. Okay, so before we dive into some questions around, and again, the staffing being the first set of questions, we wanted to provide a quick project overview, just a refresher for everyone. And so if we go to the next slide, please. Again, this is a rate study for ABA that is being conducted and directed by MedQuest. It is aligning with some separate rate studies on the home and community-based service side. And so that is also ongoing. But this is, again, concurrent rate studies that are happening that will result in a rate study report that will be submitted to the legislature prior to the start of their next legislative session. And so that is in compliance with the legislature's House Resolution 207, which was passed earlier this year. And that requests that the department conduct this ABA rate study and ultimately submit a report of the findings and recommendations. You can see the quote there at the bottom on appropriate reimbursement rate increases. So this is in compliance with that requirement. And again, all of this will be made public in terms of the study, the rate calculations that are part of that. And so before we get to that point, again, we're working with you and want to make sure we get your feedback before the rate study is finalized. Okay, let's go to the next slide, please. In terms of what is included in the rate study, just as a reminder, here are the services, the ABA rate study services that are included. And there was a question at the last call about which codes are also included. So we list all of that here for your reference. And so I won't read all of these, but here's the set of codes and services that will be included. And so we do have a series of questions that we'd like to get into more details about these different services. But again, here's the kind of the universe of services that are included in this rate study. As a reminder, as part of this rate study, we will be calculating rates, and the goal would be for implementation to post or to publish in a QI memo a list of comparison rates that would be made available to providers and the plans as a reference, as a basis for negotiating rates going forward. Okay, and so the state already publishes a number of different QI memos, including a memo and a set of rates for ABA. And so the state would continue to do so as a result of this study. Now, in order to implement new rates, in order to implement rates that result in an increase in funding for these services, there would need to be an appropriation from the state legislature. So, as a reminder, MedQuest does not have the authority to increase funding for these services on its own. It would need an appropriation from the state legislature. So it does need to go through that process. And I know that this group has been very actively involved at the legislative level, but just so you're aware that once the rate study is complete, that does not mean the same thing as implementation. It still needs to go through that legislative process and would require a budget appropriation in order to implement. So again, wanted to make sure that you're aware of that. Okay, so again, just want to do a quick, high-level description there of the rate study project. Before we dive into questions around staffing and recruitment and that sort of thing, any questions from the group at a high level about the rate study before we move on? I see someone's coming up. Is there a question?
Yeah, I was just going to let everyone know that they could come off mute and speak. And it looks like somebody called in as well. So if anyone wants to speak, please come off mute.
Okay. All right. Hearing or seeing none, we can carry on then. And I will turn it over to my colleague Dalal, and she will walk us through the next section. So thank you.
Thank you, Ben. And thank you all for joining us today. We encourage your participation in the discussion. As Sharon mentioned, please come off mute and share your comments and responses to what we're going to share today. So first, we'll start with sharing some discussion questions related to the hiring and recruiting of ABA staff. we want to understand from the provider experience, which are the most challenging ABA staff to recruit and hire, any retention strategies that you have tried, the type of those strategies, and if any of them are non-financial. We also want to understand the reasoning behind some staff leaving the organization and if they stay within the ABA industry. We also wanted to touch base on wage changes and benefits types and the staff type that are taking those benefits. So first, we'll start with the first discussion question we have here, which is, which are the most challenging ABA staff to recruit and hire from the ones that are listed here?
This is Christine Walton with Behavior Analysis Noko'oi. We've had difficulty with the RBT and the BCABA position specifically.
Thank you, Christine.
This is Emily Swazzle with ABA Steps, and we've had a lot of difficulty with the RBT positions.
Okay, thank you, Emily. And would you say this is recent? Have you experienced this recently, or has it been for a longer period?
For us, it's been since COVID. Pre-COVID, it wasn't nearly as hard. It was a challenge, but it's definitely more than a challenge now.
I echo that.
I would agree with that. The RBT position definitely being the hardest to fill. It wasn't easy prior to COVID, but since COVID and since a lot of inflation has been happening, we just can't compete with wages for RBTs.
Thank you, Carrie.
This is Fred from BTSH. Yes, and I agree with both of them. Yeah, definitely the RBT been the most stressful in our company. They are the most need, but training them, hiring them, and keeping them on is very difficult.
Thank you, Fred. So, so also add on to that, are we aware of any competitive industries where the RBTs are going to after leaving your organization, or if we know if that's where they usually try to go to? Do they offer higher wages?
This is Carrie again. I have definitely had some people tell me that they were going to Department of Education, still in an RBT position. And then a few who have gone to Department of Health Early Intervention in similar field, but not necessarily RBT. And all of that has been usually based on wages being higher paid elsewhere.
Thank you, Carrie.
This is Emily again, and I agree with that.
This is Catherine Wilson, ABA Positive Supply Services. When we have lost RBTs or when we're competing for RBTs, they're often going for the larger mainland companies that are here that have more resources to offer higher hourly rates.
Yeah, I would agree with that.
This is Fred. I have a bunch that pretty much moved to the mainland. I think the cost of living here and the wages that they get here it just doesn't equate for them, so they move out.
Christine Walton, same. We've had 5 RBTs relocate to the mainland. They've gone to agencies where they have a Department of Education contract where they reimburse higher. We've also had a few just leave to completely different fields, physical therapy, speech pathology, and then just completely different direction to the food industry, just because less response effort, they don't have to worry about progress notes, and it pays higher.
Well, thank you for your comments. Those are very helpful. And in terms of hiring and retention strategies, would you be able to share with us any strategies that you have tried and if they were successful and the type of those strategies?
We have started training our staff in credentialing programs like PEAK and PFA, SBT, and others like that. That seems to be very motivating for those that plan to remain in the field long term. We've also increased the number of benefit offerings to be more diversified, to include things like pet health care and a bunch of other similar things. That seems to help, but it's not consistent across the board. Seems to be more consistent with those that know they want to be in the field and they're working towards other levels within the field, like a BCA, BA, or a BCBA or something comparable.
Christine Walton with Benko again. We do a nice behavior analyst in training. So we have monthly classes that we, for those RBTs who are in coursework to get their BCBA. We do a nice supervision and offer unrestricted hours. So that seems to be a non-financial way to recruit. We also offer staff incentives and tenure bonuses for staying on.
Thank you. Okay. Well, the next discussion question asks about if someone leaves your organization, why have staff stated they are leaving your organization?
Yeah, and so just to add to this, I know that the group has provided feedback about some of the places people have gone. I guess, obviously, we're hearing that wages, I mean, that's pretty clear cut. If someone's looking for a higher wage. If I guess would people be willing to share some, other reasons that you're hearing, sort of non-financial reasons for, why someone might be looking to either, move on from the ABA industry or go to another line of work.
I think burnout has come up, especially more since COVID. Just how difficult it is to work with some of the kids that we serve. Yeah. And then just a lot of effort, like, the progress notes, the detailed progress notes, the meetings, all the like the non-billable expectations.
Just so I understand, you mentioned people going on to DOE, from the reason that you just gave, would you expect that to be a different level effort at DOE or something comparable? I know that that might be hard to answer, but I don't know, do you have a sense for that, or is it mostly just wage in terms of the?
I think it's wage. I think it's the schedule. I think the DOE schedule, they have breaks over the holidays. In a clinic setting, we usually are open. We're closed like I think 2 days out of the year. And then the schedule, it's pretty consistent with 8 to 3 versus our schedule is usually till 5:30 or 6. So and I do think there's less response effort with regards to it's like following individual programs versus the lead of the teacher. And that I could be wrong. So for those who work at the DOE, that you might be able to provide better feedback on that end. One thing too, I think that expectations too, because with health insurance, you know, we provide that report every 6 months. And so we're constantly making sure that the data is supporting that. I don't know what that frequency looks like in the DOE. So that might be something as well.
Hi, this is Emily again. To reiterate, and for us, another reason why some people leave are the hours. Like she mentioned, we work till 6:30, and DOE does get to leave at 3 o'clock. So that seems to be a big issue, especially for people with families.
Yeah, this is Fred from BTSH. Yeah, I mean, losing them to the DOE or the staff trying, you know, wanting DOE over the maybe clinic-based stuff that we have is definitely the amount of hours that they get with the DOE. Is, you know, you got one case, one client, 6 hours, maybe 7. You know, or with in the clinic or, you know, home-based, community-based, you know, you may be bouncing around a little bit much more than that, and I think that's stressful for our staff.
Hi, this is Angie from Windward Synergy. I'm going to kind of piggyback on what Fred said too. I think just the amount of unpredictability in a clinic setting or home-based setting where you have last-minute cancellations or a sibling in the home that's sick or other variables that were definitely exacerbated and continued from COVID. And then I think, you know, we always have work to do. Our crew could always do training or go back and look at the quality of their notes. But with bundled codes, it's really hard to, you know, budget for all of those things and provide for coverage for all of the hours for the RBTs at all of those times too, versus like in a school setting, they might have different work for them to do or assign them to a different student or, you know, be able to pay for some of those tasks in a different way.
Yeah, I would agree with that as far as not being able to necessarily pay for some of those things like material management and organization that I think in the schools, some people have been reporting like, oh, I get a paid hour of admin time every day. And with the rate, I'm to pay a wage that's livable and have the money on top of that to be paid admin time for, you know, like I said, the material, doing additional resources with particularly challenging behaviors, sort of additional like fidelity checklists and stuff RBT do outside of client specific time.
Those are very helpful. Thank you. And lastly, we wanted to touch base on the wages and the benefits. Would you please describe any recent wage changes by the ABA staff type and the offered benefits to the ABA staff?
Yeah, and maybe in particular if there's, you know, kind of during and after COVID.
We've had to increase our rates to remain competitive. And also, as I mentioned, offer bonuses as well.
And I'm sorry, was that a raising of rates or wages?
Of wages.
Wages, okay.
And is that, was that across the board or focused on certain positions?
It was across the board. I would say specific to RBTs, it was across the board, but yeah.
This is Emily again. We offer continuing education funding. We offer AFLAC services, add-ons to health insurance, paid time off, retirement with immediate vesting and matching. We offer incentives like bonuses as well, and pet insurance and a few other things, but I don't remember them off the top of my head.
This is Catherine. Yes, we've definitely increased our starting rates, our hourly rates, and increased overall we've had to increase quite a bit over the last 2 years of what we pay the RBTs.
This is Fred. Yeah. Oh, yes. We've had to increase wages. We try our best to, try to stay as competitive as possible, but we have to go right across the board and raise. But we still have staff fallout, even with that. And yeah, I mean, there's only so much we can raise. Yeah.
Just so we have a clear so primarily for somebody like an RBT, or does it seem like they are mostly offered benefits, like a full benefit in package?
Well, in the state of Hawaii, 20 hours or more consistently a week requires health insurance benefits. So that would be, I would imagine, most RBTs.
I agree. Health insurance cost is our most significant cost, right? Secondary to payroll. It's our highest second cost. It's high. Because we're smaller too, so we also can't compete, with the health insurance premium costs that maybe larger organizations can do.
Yeah, I agree as well. We do offer it, the whole package, like everybody else, but I believe our medical is kind of doubled, since prior to COVID. I don't think that has to do with COVID, but that's just more. It's just doubled. So.
So before we go on, I'd like to go back to just the first question. It seems like, so is the BCBA masters and doctoral, are they primarily a steady workforce for you? Is that a general statement that people would agree with?
Can I jump in really quick? As far as the BCBA goes for us, it's the position that we least want to lose. You lose the BCBA, you lose support for so many different clients at once.
Right.
So it's not that they're easier to retain. It's that we do have to like make sure that we're taking care of those guys. Just because the amount of effect that it's going to take, to hire somebody else, or to transfer cases and so forth.
And as mentioned by earlier,
Again.
sorry, Emily, go ahead.
No, you can go ahead. Go ahead.
Thanks, Emily. This is Angie from Winter Synergy. Just to piggyback on, that's kind of the retention program that we're using for the RBTs, is to build our own BCBAs within our own organizations, because, and then maybe that's why we haven't talked about it too, is, you know, our BCBAs are really, really, really important, and we put a lot of efforts into that, but we have less BCBAs than RBTs. So, you know, RBT needs and costs and definitely take up a lot of space. So maybe that's why we're prioritizing some of that in our talk.
I would say
what Angie said.
Go ahead. I would say, as a smaller company with right now just 3 BCBAs, I easily could use like multiple more RBTs. And if I had more RBTs, then I might be able to consider hiring more BCBAs. So right now the bottleneck is really where the RBTs are, because there's only so much that I can do without more RBT staff to implement the programs that the BCBAs would be designing.
And I do believe that BCBAs are hard as well to hire and retain, but we as a policy don't hire BCBAs from outside of our agency, meaning those that we hire, we train from an RBT on, because it's really difficult. And if you recruit from the mainland, that does happen, they do come, but very few of them are able to make it in Hawaii for a variety of reasons. And so it is as challenging, but I think a lot of us have learned to deal with or work with what we have, develop from within, and so forth.
And I think somebody else, is that a general practice that there is that promotion from within for the BCBA field?
We definitely kind of focus our efforts there.
Us as well. I think most of our RBTs are actually in coursework to become a BCBA.
I think that's a big portion of our company too, a bigger portion that we'd like actually. Part of getting them to come to work for us is that we have a program to help them, you know, become a BCBA, you know, but then that adds on to, you know, which is trying to attract them over, right, you know, to us. But we'd definitely like to have a little bit more of a balance there. But like I think like Faye is saying in the chat is something to consider as well. Getting the RBTs to look at this as a career, as an RBT, not just a career as an RBT becoming a BCBA, but a career as an RBT, and that's difficult because that's where the retention is going to be, right? If someone can see the RBT position as a career, but it's, you know, there's a lot of challenges there.
Okay. Well, thank you all for your comments. I think we can move on to the next slide now, unless if there are any other comments that you would like to share. Okay, so we'd like to turn to the supervision approach for ABA services. We understand the case supervision requirements based on the QI 2301 memo that is comprised of both direct and indirect hours. While responsive to individual member needs, case supervision generally consists of at least 2 hours for every 10 hours of service, with at least 1 of the 2 hours being direct supervision. Direct supervision must always be provided at least 5% of all BCABA and RBT hours. So some of the discussion questions we have here around supervision is to help us understand, on average, how many tech staff BCBA supervise, and to what extent does the supervision time vary by the type of the staff that is being supervised, for example, an RBT or BCABA. And we also would like to understand supervision in relation to the telehealth services. we'd like to understand the supervision requirements and if it varies by the payer type. Please feel free to come off mute, or you could share your comments in the chat.
For us, we have about, I think on average, it's about 6. So BCBs would supervise 6 RBTs, and it could go as high as 10. Depends on the caseload and the hours that are approved for the child. And we only have one BCABA at our company, so yeah.
Anybody else want to provide any feedback on the caseload? 6 to 10 sound about right, or is there anything that would have a big impact on that, on the variability?
I
It would
think the
depend
reason.
on how many hours a week. Oh, sorry. This is Catherine. It would depend on the number of RBT hours provided a week. So if I have an RBT who's providing 40 hours a week to a client versus an RBT who's providing 2 hours a week, they're definitely going to be getting different number of hours of BCBA supervision.
Another thing that we factor in is the report writing too, as well with the BCBAs. Yeah, you know, they can only, you know, they'll have a caseload, but then they could be doing 1 or 2 or 3 reports at any given time. You know, so because it's usually every 6 months, right? You know, so you know, writing those reports and all those things is factors in on how much caseload we can give them. But for our company, 6 to 10, it seems to be quite average too.
Another variable will be if a case has more than 1 RBT, right? So if a case has 2 RBTs, that BCBA is essentially doing double the supervision and work for that case.
Okay, and to what extent does the supervision time vary by an RBT versus a BCABA?
Maybe phrased differently, does it vary?
Hi, this is Noe, Bika Hawaii. I would say it mostly varies with the skill level. So BCABA will have more education training typically, so it require a little less supervision as opposed to if it's someone brand new, right, you know, just newly credentialed RBT, that's going to be a whole lot more even than a more seasoned RBT.
Okay. In terms of staff turnover, To what extent does the staff turnover vary between RBTs and other ABA staff? I think we addressed some of this earlier in the previous slide. If you'd like to add anything else to this, please come off mute to share your comments.
I mean, for us, it's always RBTs that are turning over, more than any other staff. But like I said earlier, it's has a lot to do with the value, right, of the BCBAs and BCABAs, that we can't lose them. We can, but I mean, we'd rather, that's very much more difficult to handle a loss on them. So we have to definitely make sure we're taking care of them. Not that we're not taking care of anybody else, but it matters a lot. So I don't know if you can quantify that.
And in terms of sorry, go ahead.
Sorry, I was just going to say, I think what was said in the previous comment was that, like, with BCBAs, they've already committed the education and the training to the field. They've committed to the field. So we generally see a higher turnover with RBTs.
Okay, and in terms of years of experience, would you please describe RBT or the BCABA's experience on average, and if that has changed over the past year?
And then maybe what the range might look like as well.
To clarify, you guys are talking about prior to hiring or just what we have now?
I think on staff.
This is Angie from Moon Synergy. I think a majority of our folks come to us with no previous experience at this point in time.
And for those on staff at your organization, I guess, is there an average you can point to, or maybe a range of the years of experience, at your agency?
This is Angie again. I mean, I guess it depends on how long we can keep them, right? Before the turnover. So how long do they stay with us before they go on to something else is kind of the answer. For us, we have a range right now from as little as 2 months, just started, to 4.5 years.
Okay. And so we've talked about the progression going from RBT to BCBA. Is there an average for how long that could take? I mean, is that something that happens over a 2 to 4 year period or something else? Can you speak to that?
Sure, just since I'm on the mic, I have high school graduates that we have that are 19. So them getting their undergrad and their master's degree, because you need your master's for a BCBA, is a longer trajectory than somebody who may have already had their undergrad or be in process for their master's. So it's dependent on education, and largely, can they afford to also pay for education here and housing and food on the rates that we're paying them?
So for the RBTs that first join, are you getting a number of people coming straight out of high school, or do you get some that come out of college or during college?
I actually have about half of my staff that's in college right now.
Okay.
Regarding the range, so of your question earlier about existing RBTs, I would say our range would be from just starting out to so like 3 months to 5 years. And for us, usually if we usually have a conversation after 3 years, if you're going to commit to this field, it's in their best interest to go to get their BCBA, just because with the fee schedule set, they could be in the field for 20 years and that fee schedule is the same, right? So there's only so much that we can offer them financially. So it's, and that's the reason why we don't, you know, like most, we try and push folks into the BCBA.
Okay, and thank you. So, but it sounds like if someone, just so I understand, if someone's coming straight out of high school, becoming an RBT, the full progression for them to get to become a BCBA, we're talking 5-6 years. Like they would need to be retained that long to make the full progression if they were to start right out of high school. Is that, am I about right there?
More like 7.
7 years.
And that's
Okay.
if they do a hybrid BCBA certification master's program together.
Okay.
So if they fast track, it's like 7.
So 7 is to be fast track. Okay, thank you. And do you experience that? I mean, is that you know, is that something you're able to achieve as an organization, or is that rare to be able to retain someone that long?
I feel like it's pretty rare that people make that choice to start the program right away.
Mm-hmm.
A lot of people that are working for us have not worked in the field before. And so at least the first year is them kind of adapting and saying, is this something that I want to pursue, before we can even get to that point of thinking about, you know, getting them enrolled into school.
Okay, and I see a number of comments in the chat. It's all very helpful, so thank you.
Yeah, this is Fred. Just to go back to the previous question and then add on to that. Yeah, our range is from, you know, months of experience to 5 years, but you know, really, what after a year we're already worrying about, okay, are we going to lose them? You know, and what do we need to do to keep them, right? Outside of pay. And then as far as seeing someone with their high school diploma make their way all the way to becoming a BCBA, I've been in this field for a while. I have, you know, as far as staying in one company, I haven't seen it. I see them getting their bachelor's and then doing something else.
Mm-hmm.
Honestly, yeah.
Mm-hmm.
Yeah, I do think RBTs tend to have multiple agencies that they've worked for along the way as they're getting through school.
Okay, thank you.
Well, thank you all for your comments. In the interest of time, you could move on to the next section. We will be talking about service delivery topics. We will talk about the current service delivery approach for telehealth and services that are provided outside of clinical settings. And for the other slides, we'll talk about concurrent billing and staffing and the non-client facing time. So in this slide, we do understand that some ABA codes services are approved to be delivered via telehealth and to be provided by a licensed provider in compliance with the QI health plan and the state agency's requirements. And we also understand that ABA service recipients may receive services in their homes or other community settings as applicable to optimize overall treatment outcomes. Based on these two statements, we do have some questions for discussions that we would like to address in terms of if there is any payment differentials based on the payers for the telehealth services or for the services that are provided outside of clinical settings. We also want to understand the typical staffing and the supervisory approach for those services. And in terms of services that requires transportation, we want to understand the any transportation costs related to providing those services. So first, we could focus on the telehealth questions we have here. We want to understand if the service requirements varies for other payers in terms of that services needs to be provided by a licensed ABA practitioner. And if not, please describe the impact it has on your service delivery approach.
Seeing in the chat, there's feedback on only licensed providers can provide telehealth. I think what we wanted to confirm is that while that's a QI policy, that also is something that other payers followed as well to understand if there's any kind of differences. But it seems like, is there general agreement that for other payers such as commercial, that also requires a licensed provider?
There is another payer that does allow telehealth for RBT. I don't know how many others do, but yeah, there's some inconsistencies there. And with regards to the question about the impact it's had, let's say, especially I think we see this more with COVID, because if there's an exposure, if someone's sick, the sessions would be canceled. The child wouldn't be allowed to come into our clinic, versus if it was an RBT that was able to still deliver the service via telehealth, those sessions wouldn't be canceled.
This is Catherine. I think that telehealth has made my BCBAs more effective and efficient in their supervision. Even now that we're kind of post-COVID, we've continued somewhat of a hybrid between telehealth and in-person supervision. There are a lot of benefits to both.
I'm gonna add on to that a little bit too, yeah, especially in Hawaii and the real estate, that we have to live in. It does help with the amount of people in the clinic at a time, too, as well. As long as it's appropriate and it works out, it does help out a lot. But yeah, for us, I believe just those licensed providers with the payers that we have can provide telehealth services.
And to what extent do payers pay differently for telehealth services?
I believe it's a similar reimbursement. I haven't seen any differences.
Same here.
We see a lot of feedback in the chat. Thank you for that. Um, in terms of services that are provided outside of clinical settings, would you please describe the typical staffing and supervisory approach for those services, and if the staff use their own vehicles when providing the services outside of clinical settings?
I would say for services outside of our clinic, supervision probably is increased if it's in the community. And then all of our staff use their own cars. We reimburse the federal reimbursement rate, which changes every year. I think it's 0.52 a mile. And then any parking, if they go to community outings, any parking, we reimburse that as well.
Sorry, this is Catherine. So when our staff travel from one client's house to the next, we're required by Department of Labor to pay them at least minimum wage for that travel time, which of course we do.
So so given that, is that something that's tracked from one client to another?
Yes.
Okay.
I mean, that happens automatically in our app that we use for everything.
Okay, thanks.
Well, thank you for those feedback. And in terms of the reimbursement rate, do any of the payers pay differently for those services, or is it the same as the telehealth services?
Can you clarify that question.
Sure. Is there any, sorry, go ahead, Dennis.
Oh, sorry. I think Dalal, you just had so are there rates different for clinical or community? I think you said Dalal, telehealth. So, is there a different, mainly for other payers, are you seeing different payment rates?
All payers have different rates for the different billing codes, not the locations and not the telehealth. I think Faye chimed in on the chat that it's a federal law that they have to be the same for in-person or telehealth.
Yeah, thank you. And that's helpful. I think that was it was this wondering if you had different rates for the setting. And it seems like most are have a similar fee schedule for a community versus a kind of a clinical rate or service. I think we're gonna move along unless there's any other nuances regarding the delivery of telehealth or services that are in somebody's home or in a community setting. Right. So I know one of the areas that came up in some of our previous stakeholder discussions that we really wanted to understand from a practice, um, really understand the service delivery model, and then understanding payment. When we say payment, it's maybe outside of the QI. So if you're working with commercial to see, understand if there's any kind of differences. But we got a lot of feedback around um, concurrent billing. And so we've provided here, and hopefully everybody's had a chance to look over these slides. So I'm going to try not to walk through everything that's on here, but we've provided the 97153, which is the direct treatment protocol, and then 97155 with the modification. And when we look at a BCBA, specifically for these two services, for the BCBA billing for the services, we wanted to understand that generally our RBTs also providing direct services at the same time. And then just to understand really the service delivery and overlap of the two different, and I'll just say sort of procedure codes. And if anybody's able to just sort of walk through how these services, kind of overlap and support each other, especially from that RBT BCBA coordination.
Hi, can you hear me?
Yeah.
Okay, sorry, I was having problems with my microphone. So you're saying, how do we deliver the 97153 alongside the 97155? Is that what was your question?
That's correct. Yep.
Okay.
Yeah, it really just kind of walking through the intersection of the two services and the kind of the staff delivery.
definitely. So for us, when our providers are providing 97153, they're focusing on executing the program as is written. When we have supervision or 955 oversight, what we're looking at is the data alongside them and seeing how the execution and the child's response to those programs are matching up with what we intended and what the data says. And so when we provide an on-site change or modification as to how they should be doing it, how they should be prompting or whatever they are doing to teach that skill as appropriate for that individual. That's easier to probe and test out, I guess, for its effectiveness when it's happening there versus waiting another week for us to come in and do that and look at the data. So in being able to do it alongside it, we're better equipped to make changes and not have a child stay stagnant or continue to regress because we're able to make those changes, see those changes, make additional changes to any and all parts of the program. If the child is ready to move or the adult is ready to move on to the next level, we're also able to provide that input on site about what that should look like and give guidance on how to introduce it that would be most effective for that particular participant. That is very challenging to do when you're doing it and the RBT is not there, because it's a lot harder for a lot of people to understand or visualize what that looks like outside of that session. And so when that's the requirement, it actually takes longer for the participants to progress. And it's not very efficient, at least is what we have seen.
Thank you. That's very helpful. And I think if there's anything that anybody else wants to kind of provide, but that was a great overview. Thank you.
I think it's essential for the RBT and the BCBA to be present with the client in part for the modeling. These ABA strategies are at times very specific and for that particular client. And without the overlap of the two, RBT and BCBA, you're not going to have that in-person modeling, which is essential.
Yeah, I agree with the last two statements too. And to add on to that, you know, we're working with human beings, right? Not just the client, but also the RBT. You know, you write programs and you can kind of prescribe this, but you still got to know how this interaction is working. You know, and that matters a lot. You know, and I think that's another important aspect that I don't think a lot of people, you know, can put that on paper or rule or whatever. But it does matter. When we go in and supervise an RBT, we wrote up the program. We got to see that interaction. How is it happening? How is it going? And we make definitely changes depending on the interactions that we're seeing too as well.
Thank you. Anything else about the two services?
Hi, this is Angie again. I think just to put a clear thought in there that the RBT and the BCBA at that time that they're there together both have very well-defined roles at that time and are doing two very specific different jobs in tandem with each other. So I think sometimes with people outside of the ABA field, it gets misconstrued as like, but there's only one child there to deliver or adult, there's one person to deliver services to, but there's really two different things that are happening in tandem with each other. So I might be modeling in 1 minute, then updating curriculum in another or an intervention in another, and then probing something in that next. So it changes and it's a back and forth kind of tandem relationship throughout that session. But both people have a role that's separate from each other, if that helps at all.
Thank you. I greatly appreciate it. I think you've all did a fantastic job giving the going to clarify that. I'm going to move on. I know I want to be conscious of time. Everybody has a very busy days. So when we look at the two, we've provided two different procedure codes here for an assessment and then treatment for maladaptive behavior. These require the administration by BCBA, the assistance of 2+ technicians, and then the environment customized to patient behavior. So I think generally when we wanted to sort of have a similar discussion around the overlap of this, from the 2+ technician and the interaction with the BCBA from a billing perspective, and that's certainly want to understand if there's anything on the service delivery that you'd like to provide too. But do any of the billers that you or payers that you work with allow for the billing of both the BCBA and or the technicians, or is it billed at the something like the BCBA rate? Thank you. Appreciate the comment that the services, um, the the codes are very rarely used.
Yeah, if we're gonna need 2 staff and you're gonna get paid the same as just having one, we must just take that as house money at that point.
Thank you. Okay, so I think the general takeaway, what we were to walk away from this slide is that those are services that really they're cost prohibitive as currently structured. So they're not currently provided and or billed for. Okay, thank you. Appreciate everybody's feedback. Chat over the phone. Okay. When there is so kind of a more of a continued staffing discussion, um, there's a series of questions that we wanted to talk through, um, regarding what is the typical time of case supervision for a 15-minute unit. Really, and with I think the 5% requirement, is that something that typically will stick to, or is there going to be anything else that you could come up with sort of a general proxy of of supervision for a 15-minute unit?
I would say that the 5% is like bare minimum, and that's for probably an RBT who's pretty skilled and has been in the position for a while and is pretty familiar with that client. but on average, I would say 10 to 15% supervision is much more likely.
I think it varies for child and provider for us as well. Again, the 5% is in those rare occasions for providers that are extremely skilled and you know, could probably perform as a BCBA minus the credentials and so forth. However, the amount of supervision or oversight any participant or case receives largely depends on their performance and needs. And since we tend to use PFA SBT for our severe participant, which make up the majority of our participants that we see, supervision is frequent and often to ensure that we're not seeing any maladaptive behaviors that pose a risk to themselves or others, that we're making the changes as effectively and quickly as we can to see them progress and go from there. So it also, because of that model, tends to be that we tend to have a lot more oversight at the very beginning of their service and then fade down, but we don't get anywhere near 5% unless it's with a very skilled, very tenured provider and a participant that is almost ready to transition.
Thank you.
Our standard is 10% or more.
So I'm hearing generally it's going to be about 10%. And but that is like all of the service delivery, and a lot of it is dependent upon seniority of the person delivering the service, as well as the needs of the person being served.
But to go back to the responsibilities, right, of the RBT, right, is not to, move programs, stuff like that. So if you're coming in only at 5%, there's a good chance you're gonna miss, I think it was Emily that said earlier, but you're gonna miss opportunities to move the programs where you need to, even if you have a high skilled RBT. Yeah, so I think, for our agency, definitely we don't like to be near that 5%. We want to be higher than that.
Thank you. Anything get the continued comments in the chat. I guess I want to there anything else regarding concurrent staffing, case supervision, regarding kind of the billing or payment side that you'd like to um, discuss or opine on?
Well, I would just like to say that you're aware that not all insurances pay the concurrent, right? So there are insurance companies that if the RBT and the BCBA are there, you can only bill for one. And I personally don't choose clients from that insurance company as much because of that.
We are, yeah, and that is when we had a couple of questions regarding variation by payment. I think that is one area that we, knowing that some insurance companies or some insurance will pay for concurrent. For instance, QI does not. So we definitely do appreciate those differences, and I think generally if you have any comments or feedback around how common that concurrent billing is allowed, that's helpful context for us to understand. So I guess is it more common to find a payer who will pay for that, or is it more common that it is not, you know, paid for?
For us, it's more common that you find payers paying for the concurrent billing. And I think for us, and probably on the insurance side as well, is if you don't allow the concurrent billing, as far as just the billing standpoint, I think you're asking just the billing part, then you're really looking at a lot of auditing going on, double checking, triple checking. You know, it's all gotta sort of all make sense between the two when it gets to the insurance company. I'm sure the insurance company got to do the same thing too. You know, that, you know, you have to watch that you don't make any mistakes. You know, if the time says that they overlapped, you just part way through the session, then you have to make sure your billing represents that, and not all programs that our providers use. We were on one that did split it, and that was kind of cool. But when there was a mistake and we found that there was a mistake, to unsplit it and then send it back to the insurance company, you know, for correction, that was extremely difficult. Now we're on a different system that doesn't split it. Now we have to run audits prior to billing. It's a hassle. It is. It takes a lot of extra time.
Thank you. Appreciate the feedback from Catherine and Emily. There are a series of questions that we had regarding indirect non-client facing time, and you know, for time-based services, you know, that are, when we look at sort of these different services, um, do you typically, how much indirect time do you find are associated with your assessments, with your treatment services? You know, and this may be something where, you know, we could also take your comments offline if it's easier to do it that way. Um, but just, is there any immediate feedback on the time commitment for things like report writing, for documentation, regarding any of these services, and it's helpful to really understand that within the context of 15-minute unit. But even as you look at these different services or assessments against each other, to try to help provide an understanding of the indirect time associated with each one of those.
Can you clarify if you're putting that towards, because your BCBA is going to be a lot different than your RBT. So is there a particular place that you want to focus?
Yeah, I think if we start with the RBTs, that would be helpful.
I mean, from an RBT standpoint, really their main part is to deliver the services per what we've written in the treatment plan and write a note for that. So, you know, and then to receive supervision outside of that, but then that, you know, includes BCBA time. I don't know if I just confused that, sorry.
Could you say that? Oh, go ahead.
If it helps, like we give our RBTs 15 to 30 minutes of non-client facing time per session that they have that we pay for as administrative time. That's not billed through the insurance. So it's part of our budget. And then we also have roundtable discussions, treatment team meetings. Those are things that we pay for. We don't bill insurance for. And then there's also individual supervision time in addition to that.
And if you were to think about the context of an RBT's day, is there an approximate percentage that you could think through?
I know everybody's setup is completely different, but we have a clinic set up and we run 2 block schedules. They have 7 hours of client facing and 1 hour of admin per day for an 8-hour day.
Thank you. That is.
I'm sorry, can you repeat your question one more time? I must have missed it.
The question was, if you were to think about an RBT's day, approximately, could you think about a percentage, a rough percentage around how much time they're spent for indirect care time?
About similar to what was just said, 1 out of 8 hours for us.
I think for us, it's about 10 to 15% for non-direct time.
Okay. Thank you. I do want to get to next steps because 90 minutes is, we appreciate all of the time and the discussion that you had, and I will just sort of as a reminder, all of the ABA materials are posted to the MQD website. We are looking at, as a reminder, there was a provider survey that was sent out. The deadline for that was extended to Monday, the Monday that just happened previously. And so we are compiling those results. And as Ben had mentioned during our kickoff, these discussions help provide some validation and some context to those provider surveys. And so we will be taking the information from today's meeting, from the provider surveys, and developing comparison rate calculations, as well as completing a benchmarking exercise for the next stakeholder meeting, which will be taking place December 4th. And as we had mentioned, the rate study and the budget estimates will go towards the state legislature for future funding consideration. I know that towards the end, we did start to we went through some topics that were fairly quick. Everybody also does have the presentation. So if there's anything that you think would be helpful, we do encourage you to submit feedback to our inbox, which is on the slide. It's also on the presentation that was sent out and distributed to everybody. So we really do encourage your feedback. We want to hear from you. Any kind of information that is related to this study is only going to strengthen the results. So with that being said, I know we are 1 minute over time, but if there are any questions or anything else, I'll stay on the line for another couple minutes, but also encourage the use of the inbox as well. Any parting comments before we leave?
What is your response time for the email? Because I know I had a question about the survey, and then I sent an email, I didn't get a response. I filled it out and I took notes on that. I added a note to that. But what is your general response time for the to receive a feedback or a response through email?
Yeah, we'll look at the inbox, make sure that those have all been addressed. If you have any feedback, we'd look for that by the end of the week. So by the end of the day, Friday, just knowing that we have the meeting coming up at December 4th, but any kind of follow up, we'll make sure we get to you as soon as possible, and within the next 12 to 24 hours. So.
Right.
Anything else? Well, thank you all for the 93 minutes today. We appreciate the feedback and the discussion, and we're looking forward to anything you may send to us via email, but also getting together again on December 4th. So thank you.
Thank you.
Thank you all, folks.
Thank you.